So I'll try and do three things. You can't really talk about the results or appreciate the results of the Global Burden of Disease study unless you know a little bit about it. So I'm not going to give you a lot, but I'll give you some brief background and methods of the GBD study. It's a study that Chris Murray from Harvard, now at the Institute for Health Metrics and Evaluation via WHO, and I started 30 years ago. My hair was a lot different then, and it's still going. I'll then talk about some of the key findings. I asked John, well, what do I do? Because there's billions of these findings, and he said, well, focus on Australia and the Asia-Pacific region. So I'll try and do that, but I will give you some of the global findings and implications, and then talk a little bit at the end. What's, I think, most important for this audience is some of the implications coming out of that work, and I'm going to cheat a little and supplement that with some recent research that colleagues and I published in the International Journal of Epidemiology, building on what Mike Shearer said earlier. He said it very sleight of hand, but it's actually a very, very important public health challenge, Mike, and that's the slowdown in life expectancy gains and mortality declines in countries like Australia. So I'll focus on that as well as an example of how I think one key risk factor is playing out and is going to be important for your discussions here. So the Global Burden of Disease study by numbers, we like to think of it as a systematic, scientific, global effort to compare the magnitude of health loss. Keywords there are health loss. John's talk and others talked about QALYs and various measures that are used and also in the health economics literature. We're not going to talk about QALYs. We talk about the loss of health induced by diseases and injuries and risk factors. And we do that in a way that policymakers, if they want to, can assess in a comparative fashion with confidence, at least as much as the data will allow us, is road traffic accidents more important as a cause of health loss in Sydney than HIV, than unsafe sex, than high blood pressure, etc., etc. So we have a framework to provide health loss for all of that, all major diseases, injuries and risk factors. And we don't just do it for one age group, we do it by age, by sex, by location, and every year since 1990. There are, sorry, that shouldn't read 2055, 205 countries and territories. We do it every year. We do sub-national assessments. It'll be not great, maybe in my lifetime. It's actually rising very quickly because we're now doing sub-national assessments. What does it mean to have a burden of disease for China or India? You've really got to drill down. And we're starting to do that at the first admin level for all these populations. It's, according to Richard Horton, the largest, maybe because he publishes it, the publishing scientific collaboration in the world. When we originally did this, it was Murray and myself, an expatriate New Zealander and an expatriate Australian at the World Health Organization. We now have almost 5,000 collaborators, some of whom might be in this room, working with us from over 150 countries. We quantify disease burden from almost 360 diseases, over 3,000 sequelae of those diseases, and importantly for our discussions this afternoon, more than 80 risk factors. Each time we do it, the next round will come out in May 2020, at the time of the World Health Assembly. That will be GBD 1990. We produce over 24 billion estimates, hence my question to John about what he wants. It's updated annually and published in The Lancet, and there's various other places you can find it, including a very interesting website which has visualizations. To summarise very quickly, what do we mean by disease burden? Well, we measure it using this metric called DALYs, Disability Adjusted Life Years, which is the sum of premature mortality. It's simply the age at death multiplied by a standardised life table function saying how much life you would lose. And we also add to that, streamed out into the future, the impact of non-fatal events today. So if you don't die from a traffic accident today, but you're severely disabled, that's a health loss. We need to measure it. Society needs to know that that's preventable, and they need to know how big it is and how it's changing. And so we measure, somewhat controversially, years of life lived with disability by looking at the prevalence of a condition multiplied by a disability weight on a scale of 0 to 1. And we've heard a little bit about some of the methods for disability. I won't go into them, but if you want to know a little bit more, I can give you an idea, very similar to what we saw this morning, using the economics framework to get disabilities. But the reason I say it's controversial, because when I was first giving talks on the GBD, people would accuse me of weighing lives and being unethical, but we're not interested in whether a person who's disabled is less or more of a human being. Of course that's not the case. It's a matter of measuring the disability that they suffer from while they're still alive. We also do healthy life expectancy, but I won't show many results. We also do the traditional measures such as incidence, prevalence, that all the epidemiologists among you would know. This is a simplified, I kid you not, this is a simplified version of what we do. There's 4,500 of us now. So each of these boxes, this is mortality, child mortality and adult mortality. Over here is causes of death in green, and each of those boxes breaks down into 15 or 20 sub-boxes and sub-steps that need to go through. Fundamental premise of burden of disease is not to be happy that we've got data on disability prevalence, say in Australia, but to ask the question, what's wrong with it? How can we use these data? How can we use them in a comparable way? So we go through lots and lots of screening processes. Down here is the YLDs, all the non-fatal measurement. Over here, somewhere, this is cause of death, non-fatal. This is risk factors. And to drive a lot of our methods, somewhere in here is covariates. Somewhere hidden in blue in here is the outcome of interest. DALYs due to risk factors and DALYs due to injuries and diseases. The approach to estimation, I could go through pages and pages of methods, but just to summarise, we estimate relevant quantities of interest for all age, sex, locations. Just because we don't have lung cancer data for Mali doesn't mean we should not estimate or drop Mali from the Global Burden of Disease Study. So we try to estimate it, and we do that primarily using disease models. We've developed a model called the cause of death ensemble model, which is essentially based around covariates for disease, a little bit like the weather. The weather in Sydney is not predicted from a single model, it's predicted from an ensemble of models, which have been demonstrated to be superior. We have a method called DISMOD, which is the only way that Murray and I 30 years ago could make sense out of disparate, often wrong, often conflicting data on prevalence, incidence, case fatality and mortality. How do you get those together in an epidemiologically consistent way? We use DISMOD. We also get our estimates using spatial temporal Gaussian process regression, for those of you who are interested in the actual methods. We calculate uncertainty around everything we do, because we believe in interpreting the global burden of disease. It is very important to be honest about how much you don't know, just as claiming how much you think you do know. And so we put uncertainty, and so for estimating lung cancer in Papua New Guinea, the uncertainty goes from 5 to 500 per 100,000. That is absolutely useless for policy. And so we're working with the government of Papua New Guinea in another project that I lead at Melbourne to try to improve those data. And we do model performance by testing out of sample in all cases. That's all I'm going to talk about, methods and background. I'm going to show some of the findings of the GBD, firstly globally, and then clip in some of the Australian and regional information. So this is what we found recently published in The Lancet in 2019. This is GBD 2018, is it? Or 17? Lost count. It just shows mortality from 1950 right through to 2017 by year. And it shows in one graph the demographic transition that I think is extremely important for this group of collaborators. Back in 1950, all those in red, of the 44 million deaths we think occurred in the early 1950s, half of them occurred among children and young adults. Not a whole lot occurred among the elderly in blue and green. But as you wander through time up to 2017, we now have less than 5 million children dying a year. Now that's 5 million too many. It's an unfinished agenda, but it's a lot less than the 20 million we had in our lifetime back in the early 1950s. And so, this is some of our lifetimes. And then here you can notice increasingly at the older ages in blue, the massive increase in mortality as we've been successful in postponing deaths later and later in life. Those of you who are wondering, 1958, 59, this massive increase in mortality was the Chinese famine. This is life expectancy at birth, again, something that's relevant for us in global health and particularly in the elderly. This is life expectancy since 1950 to 2017. This is the high-income countries classified by the World Bank. Pretty much a straight line until 2011. Go back to think about what Mike Shearer's told us earlier. Instead of slowing down, it is slowing down, and I'll come back to that in a moment. This is a major new trend in epidemiology and high-income populations of direct relevance to health of the elderly. The global average is here in black. Again, Chinese famine, not fantastic for life expectancy. You can see a big dip here, but more or less a straight line going up. A couple of others of interest down here. This is sub-Saharan Africa. Life expectancy always lower than elsewhere. This big dip here in 1994 is the Rwandan genocide. But then since the early 2000s, look at this steady and amazing pickup in life expectancy due to effective treatments for HIV and malaria in particular. So Africa is now back on track. The only other one I want to point out is Eastern Europe, Russia and neighbouring and former Soviet Union. Big dip in life expectancy around the Gorbachev years. This is the impact of the alcohol epidemic in Central and Eastern Europe, and only in recent years have we seen them back on track here. Many other stories there, but I don't have time to go through them. This is a graph of those YLDs. Remember, this is the prevalence of disability times a disability weight on a scale of 0 to 1. And this is by age, from 0 right through to very old age. And this is for the world, I think, global YLDs, yeah. Important to note here is the light purple, which is a big slice at the younger and adult ages. These are mental health conditions. Mental health, substance abuse, not often fatal, but causing tremendous health loss. And as we get older, we've diabetes clipping in here, and more importantly, we have musculoskeletal conditions getting more and more important as we get older. I'll show you that graph for Australia in a moment, but just to give you the global picture and to finish it off. So here's, if you're Director General of the World Health Organization, when you wake up every morning, what it is that should be driving you. And this is 2017, sorry, this is 15. I haven't quite updated it, but it's a similar story. Sorry, let me start over here. This is 1990, the leading causes of disease burden, that's DALYs, worldwide. Pneumonias, neonatal conditions, diarrhea, ischemic heart disease, stroke, some more neonatal encephalopathies, malaria, measles, COPD, road injuries, number 11. By HIV was down at number 42. By 2005, HIV is number 5, a massive increase. And ischemic heart disease, heart attacks, the leading cause of DALYs worldwide, pneumonias, stroke. Look at the mixture. Blue are non-communicable conditions. This is worldwide. This is not just Australia, worldwide, all ages. Red are communicable diseases, pneumonia, HIV, diarrhea, malaria. And the green are injuries. And then by 2017, you can see this epidemiological transition worldwide is even further advanced. Ischemic heart disease, stroke, low back and neck pain has now crept in to the leading cause of DALYs. Incredibly prevalent, incredibly disabling, incredibly ignored by health systems, and yet it's the 4th leading cause of health loss worldwide. Now, a few notes for Australia. Again, the same sort of graph, 1990 to 2010. Low back pain was the leading cause of YLDs in Australia 30 years ago, remains the same today. No, low back pain. Depressive disorders, headache disorders, still in the top 3 or 4. Falls has increased from 4th to 2nd. You can see there anxiety, major depression, and so on. These are the non-fatal conditions that the health system in Australia needs to deal with. And you can ask yourself how well they're doing so. And this is that same graph for Australia by age. Again, a very, very similar picture. At the younger adult ages, all of this in here is mental health and substance abuse. The darker purple here is diabetes. The brown is, as we get older, is musculoskeletal, particularly back and neck pain. Very, very similar. You can see some of the others, some of the injuries, traffic accidents, falls are here. Now, what's important is, and I think some people have already mentioned, I think Julie Biles talked about the fact that when you get older, there's an awful lot of the population who are disabled. And so what we have here for Australia, it's 2010. I'm sorry, it's a little old, but the age curve would be very similar today. Notice these two lines. Blue is 1990, red is 2010, and the dots are males, the solid lines females. They're all extremely similar. In other words, the age pattern of YLDs, disability, is extremely common and similar and invariant over the last 30 years. And if we look at the rate of change of YLDs since 1990, this again takes the 20 years up to 2010. I doubt it would be very different today. And you can see the rate of change of YLDs, no matter what age you are, including the elderly, is pretty much close to zero. This is the uncertainty interval up here. So there's massive uncertainty around that. But as best as we can measure, in countries like Australia, disability rates have not changed at all. When you think of the big things causing disability in Australia, back and neck pain, substance abuse, mental disorders, have they declined in prevalence and incidence? Probably not, at least not according to that measure. Just to complete the picture on mortality, leading causes of death in Australia, you're pretty familiar with this, I'm sure, ischemic heart disease. Now, Alzheimer's is an interesting one. From the ABS data, it's gone up from third to second, and I think Kaarin's going to talk a little bit more about that in a moment. The question is how much of that is real. This is a very significant cause of death, which, according to the ABS, is about to overtake ischemic heart disease as the leading cause of death in Australia. And yet we don't see a comparable increase in prevalence. So we think that, we don't know how much of it, but we think a lot of the a lot of the increase in Alzheimer's is due to doctors over-certifying Alzheimer's disease. I'm interested in some reactions to that. I just don't feel comfortable about putting it up there. I think this needs a lot more research. People may well be doing that. Some of the other stuff's pretty clear. Lung cancer was the fourth leading cause 30 years ago. It's the leading cause today. COPD. All of this you'll recognise as being very closely related to a risk factor that matters an awful lot to health in the elderly, and that's tobacco smoking. Some of the others there you can pick up and see yourself. Now, moving on to what John actually asked me to talk about, which was risk factors. This is the framework we use in the GBD. So we have disease burden, and I've shown you some highlights of that. But what we need to estimate for those 84 risk factors and clusters is the current distribution of a risk factor in a population by age and sex. We need a counterfactual distribution. So the only way we can quantify disease burden from risk factors is by the counterfactual approach. In other words, to say, well, what if, and in this, let's take tobacco, what if 100% of the Australian population had never smoked? Not smoking today, but had never smoked. What would be the difference in disease burden in Australia today compared to what we actually calculate? And that's what we attribute to disease burden to tobacco. Now we go back and do the same thing and said, what if 100% of the Australian population had optimal blood pressure? Now that's not zero, clearly, because we dropped dead. So what is the optimal theoretical minimum systolic blood pressure that would result in minimum population hazard? And we've got that from EPI studies and the collaborators we work with. And then we recalculate the disease burden as if all Australians were at that optimal blood pressure. And that's what we attribute to blood pressure. Now you're seeing a pattern here. These are not additive. I can't add tobacco with blood pressure, with cholesterol, with body mass index and so on because of the counterfactual framework. What I can do is feel confident that the comparative order of risk factors is what people should be aware of. So that's what we do. We get this counterfactual distribution from our disease experts and our risk factor experts we work with. We look at all the science on risk accumulation and risk reversal. When you stop smoking, what happens? Multiply that by disease burden, and we get the attributable disease burden at various years. So here's some of the risk factors we look at. For those of you familiar with the GBD study or the Lancet, we do water and sanitation. The ones that policy are interested in: air pollution, environmental risks, child and maternal undernutrition, tobacco, secondhand smoke, alcohol, somewhere in there, the metabolics, cholesterol, high fasting plasma glucose, things that would be of direct relevance for your discussion. Here we also do a lot of diet. Richard Peto is not exactly happy with the way we do diet, so we're convening a big scientific symposium in Oxford in March this year to go carefully through what we're talking about in diet. And some of this diet stuff, the evidence is becoming less clear, and so they've been removed from the list. I think omega-3s somewhere in there are no longer quantified because we're not convinced about the evidence down here. So it's a changing feast, but we're trying to move beyond. For public policy, diet doesn't mean a lot. So it's what components of diet that policy can act on. And then occupational exposures. This is just a sample of them. There are more risk factors, but I haven't got time to show them. So worldwide, what does that mean? What are the big causes of disease burden worldwide? High blood pressure. You may be surprised by that, but high blood pressure is extremely prevalent in developing countries. Look at Africa, India. High blood pressure is very, very prevalent, and untreated, we know how fatal it can be. So if the entire world in 2016, this is both sexes, had that optimal systolic blood pressure, the disease burden worldwide would have been 9% less than what we calculated. If the entire world had never, ever, ever smoked, in 2016, the world would have been 7.5% healthier than we calculated, and so on. And the colours there show the causes through which these risk factors operate. High fasting plasma glucose, high body mass index, I'll come back to that later, ambient air pollution, alcohol, cholesterol, household air pollution, and so on. You can see them there. Now, I've shown this graph just to show that we have a public health responsibility, which actually John Beard reminded me don't do very well in the GBD, and that is communicating these findings to policy about what is going on and what really matters. And this graph tries to do that. It looks down here on the x-axis at the number of attributable DALYs. It's on a log scale. So this is the size of the problem from a risk factor. These are all the GBD risk factors. On the y-axis, we take the annualized rate of change over the last 20 or 30 years. So you don't want to be up here, which is big and growing. You want to be down here, which is small and decreasing. And a lot of the world is right in the middle. But out here, in the bad quadrant, if I can get a little closer, the two that really matter, that are big currently and getting bigger fast, are body mass index, the world is getting fatter, and fasting plasma glucose in terms of diabetes. The others, smoking, for example, is down here somewhere. Someone can see it better than me. If I look on this. Right, thanks, John, over here. So smoking is still big, but it's coming down. Interesting. So we are having some success in global tobacco control. Here's Australia, the same picture. Unfortunately, I've used the wrong scale down here in my hurry, put these slides together. These are DALYs, I should really have percent, but this is the rate of DALYs. The picture's the same though, the relative order. Largest risk factor in Australia still, despite the massive declines in smoking prevalence, 15% of Australians still smoke every day, is tobacco. High body mass index, not far behind. Then this amalgam of dietary risks, high blood pressure, high fasting plasma glucose, alcohol. Look at the spectrum of things through which alcohol operates in Australia. And so on. Drug use is down here as well, and this is particularly important in the context of the opioid epidemic that Australia, the US and similar countries are experiencing. John also asked for some Western Pacific data, so I've just pulled out the WHO Western Pacific region, which is a mixture of many things. It has Australia, Japan, but it also has China. So this is primarily driven by findings in China. But the leading cause of disease burden risk factor in the Western Pacific region is diet, followed by tobacco, driven by the Chinese, high blood pressure, high fasting plasma glucose. You have to go a fair bit down this line, down here, to find malnutrition. In other words, the epidemiological transition on our doorstep is happening very fast. It's not going to happen, it's happened. And it's getting worse and worse and worse. And that has had implications, particularly for the elderly, because that's the age groups in which these risk factors are increasingly concentrated. So very high order, there are 4 transitions that we've discovered over the last 30 years or so of GBD work. Demographic transition with disease burden progressively shifting away from children, it's still there, some of it, but away from children to older adults and the elderly, however they're defined. Disease transition, where more and more of the disease burden is now moving from communicable, maternal, neonatal to non-communicable, including mental health. Disability transition. Australia was the first country in the world in 1998 where the fraction of disease burden from YLDs exceeded the fraction from YLLs. And so we've seen that progressively in many more countries. A risk transition where we're seeing a move, as I showed you in a moment, away from the older traditional risk factors of malnutrition, unsafe water and hygiene, air pollution, to this amalgam of what we talk about as diseases of lifestyle. And that's happening everywhere, with one warning, except in sub-Saharan Africa, where the MDG agenda is still very relevant. Okay, finally, in my last few minutes, I promised you an example. What I want to do is highlight on this guy, obesity. Just pick up on obesity because it's the one thing we have not grappled with. I showed you in that graph there, obesity was in the right-hand corner. It is not going down globally, and it's already causing a lot of disease burden. This is the fraction. I think I've taken women here. I don't mean to pick on you, but just in choosing one of the sexes, so I've chosen women. Adult women, the fraction who are obese, this is not overweight, it's obese, defined by BMI of 30 or above. More than a third of Australian, American, Mexican, Russian, North African women are obese, and it's very similar for men. This is Australia. I'm sure you're familiar with these data from the ABS. This is overweight, and overweight over here, about overweight and obese, sorry. You can't read the numbers. This is 50%, so it's about 2/3 of Australian men, about 2/3 of Australian women are overweight or obese. Over here, you can't read the numbers again. That's 50, I think that's 20. Yep, it's 20. So that's about 30% of men and 30% of adult women, including several of the elderly, age groups of the elderly, are either obese or overweight and obese, and particularly 1 in 3 being obese. Why does that matter? Graphs from Richard Peto, work that he's done with collaborators, again impossible to read, but along here is BMI, and along here is it all causes or is it, I think it's, yeah, all causes. So all causes, obviously the very thin have a higher risk of mortality. The lowest risk, this one here is for non-smokers, I believe, and this one over here is, sorry, this is smokers and this is non-smokers. So smoking is about the dumbest thing you can do because it raises your risk of mortality irrespective of your body weight. But if you look along here, the minimum body weight is about 25, a BMI of 25, and then the risk increases pretty much linearly as you get fatter and fatter. So by the time you get to a body mass index of about 35, I don't know what that is in kilos, but it's a lot of kilos, your risk of mortality, of dropping dead, is about the same as a current smoker. So that is a very, very important fact for global epidemiology. This is Australia, just to show the trends from 1980 to 2010. They're not by age, but you can see here males in green, females in purple. Since about the mid-1990s, a steady increase in the numbers. Look at these numbers, about 5 million Australians overweight, about 2 or 3 million men, about the same number of Australian women overweight, and there's no sign that this is slowing down. Now, the reason I show that is to show this graph, which I hinted at earlier, and I'll finish with this. This is the long-term decline, I think Mike Macheras mentioned this morning, the very incredible declines, about 70 or 80% in cardiovascular disease for men and women, mortality rates in Australia, huge declines from 1,200 down to about 300 for men, 800 down to about 200 for women. What I want to draw your attention to is the last 5 or 6 years over there. And if we put this on another scale, and on the right-hand side we have annualized rate of change, then back here the rate of change of these mortality rates was still around about 4% a year, still declining nicely in the early 2000s. It then started to slow down, And by about 2011, the rate of decline of cardiovascular disease mortality has progressively slowed and is now, as Mike reminded us, is increasing in Australia. And we're not the only country, that's the United States. America, perhaps even more extreme, and occurred a little bit earlier than Australia. So I'll finish. That's epidemiological evidence that not enough people are taking into account that has direct relevance for survival and health of elderly populations. So let me just summarise this graph, which I've somewhat controversially titled Overweight and Obesity, the New Tobacco. In other words, is this the risk factor that we should really be paying more attention to in Australia? Because we're not seeing any success in bringing down population levels of overweight and obesity. There's some substantial evidence, obviously, that it's increased dramatically. There's some evidence that has stabilised. It hasn't come down, but there's some evidence that the increase has stopped, particularly in more recent birth cohorts. It seems to have attenuated. In many developing countries, prevalence, particularly Middle East, Latin America, is likely to increase. And it's unclear what the population health NCD implications are, especially for the elderly. Will rising prevalence and high relative risks increase NCDs, or will they be attenuated through health system responses? Is the Australian health system going to cope with this? How will they know? How will screening programs identify people who might benefit from blood pressure treatments, cholesterol, diabetes treatments, and so on? Big question, throw out to you. Finally, the big question that I'd like just to draw your attention to, going back to this issue of non-fatal disease and injury burden. This has already been explained by Mike and others, this long-running debate about whether we have a compression of morbidity. As we live longer, will we live fewer and fewer years in poor health? That's the dream, and as the GBD evidence shows, that dream is wrong. What we're observing is an expansion of morbidity, not a contraction. For example, if you take all the high-income countries over the last 20 or 30 years, the increase in life expectancy has 2.8 years for females, has been greater than the increase in healthy life expectancy, HALE, which is 1.7 years, and for males, life expectancy has gone up about 3 years, but only 2.5 years for healthy life expectancy. In other words, the biggest causes of YLDs, mental health, musculoskeletal, neurological, diabetes, etc., the rates are not declining, even though we're increasing, or have been increasing, our survival. In Australia, I pointed out, YLDs are now much bigger, about 60% compared to 40% of DALYs from YLLs. And how is the Australian health system, how are other health systems coping and adapting with that trend? And finally, a research need. As a researcher, it's a comparatively underdeveloped understanding compared to cardiovascular disease and cancer. Underdeveloped understanding of the leading risk factors for those main causes of YLDs, mental health, and particularly neck and back pain. We have, as a research community, a lot to do. Thanks very much.
So good afternoon, everybody, and thank you for the invitation to speak to you today. And I'd also like to congratulate John again. I thought I'd talk about these economic, social, environmental enablers as part of this session that I've been invited to speak in. So I usually talk about lifestyle and cardiometabolic risk factors for cognitive decline. So this is slightly different, but we do look at all of these factors that influence cognitive and brain ageing when we're trying to put the big picture together in trying to look at risk reduction and ultimately prevention. So first of all, because we've got a very diverse audience today, I thought I'd go back to basics and explain what is cognitive and normal brain ageing, because we actually do have some normal cognitive decline that all of us experience, which is not dementia, and we also have normal brain ageing. So we need to be able to distinguish that from pathological cognitive and brain ageing. So in normal cognitive ageing, we have stable, if not increasing, verbal ability over the adult life course. We start to see more variability both within and between persons in old age in cognitive abilities. We do see memory decline in normal ageing. That's not dementia, so that's just experienced by the average person in the population. We see decline in executive function, so that's that higher level decision-making ability, And the reason we have decline in memory and executive function is because the brain doesn't age uniformly. So there's parts of the brain that age more rapidly in the frontal lobe, and the hippocampus age more rapidly than other parts of the brain. We also see a decrease in cortical density, and we see shrinkage in the myelin, and that results in slowing. So one of the most ubiquitous observations of ageing is slowing, behavioural slowing, slowing in walking speed, and cognitive slowing. So that's all normal. And we also have changes in the neurotransmitters in the brain. And on the right, there's a very famous depiction of this cognitive ageing, where we have some abilities that are stable and some that decline. I just wanted to put this into more practical, understandable data. So this is just some very, very basic descriptive data that I pulled from the Australian Diabetes, Obesity and Lifestyle Study, which is a representative sample of Australian adults aged 18 and older. And at wave 3 we were able to put cognitive measures in, and we had about 6,000 people who completed the cognitive test battery. And so, just want to check. Yes, so up here we have verbal ability, which is, as I said, you see these are between person differences, they're age differences. In Australia, you can see the average Australian verbal ability actually increases a little bit with age, which is what we'd expect. Down here we have scores on a memory test. This is a 15-item list of nouns that the person had to remember. And you can see here, this is the normal ageing you'll observe in the population, unadjusted. You'll just see there is a decline of several words throughout adulthood, and that's what we see in normal ageing. Likewise, this is the raw scores on a measure of processing speed, where the people have to code a task. They have 90 seconds to code some symbols. And this is what you see, just normal population ageing, of slowing of processing speed. This is our dementia screen, the mini mental, and you can see that there's a sort of funny distribution here, and that's because we are starting to see people over 60 developing cognitive impairment. And you'll also start to see these people who are dropping, and these are people who, if we did a clinical workup, we'd find these people were developing dementia. So that's just what the data looks like at the population level. So we do have quite significant cognitive ageing. In terms of the brain, we know that there's a lot of brain shrinkage in ageing, and what's probably not well known is that a quarter of the brain ageing actually occurs before the age of 60. And for those of us who work in prevention, that's really important, because it means that our risk reduction programs and policies and interventions really need to start younger, and that there's a lot we can do before old age commences, or before we move into that period. So I think that's just wanted to alert you to that, because it's not widely understood. So the whole issue with cognitive and brain health and looking at ageing well is that these are not predetermined trajectories that we're on. So when I started my study as a psychologist, we were told that we were born with a fixed number of neurons and that this wouldn't change. And in the last 20 years, there's been so much research, and that we have two concepts that really underpin everything that we're doing in the area of cognitive health. And the first is neuroplasticity. So we think that the brain is quite plastic, and even in people with dementia we can see some new learning. So underpinning all of our interventions is an assumption that the brain can change, and we can see changes in structure and function. And we see things now like studies of animals who are given, so mice given exercise interventions, we're seeing regeneration of the hippocampus and things like that. So we all base our research on an assumption that there is neuroplasticity, and there's also changes in the neurotransmitters such as the brain-derived neurotrophic factor, which is moderated by physical activity levels. The second important concept that we work with in trying to explain cognitive and brain ageing and thinking about optimising healthy ageing is that we have some type of cognitive or brain reserve or resilience. Now, this concept was actually first developed in 1988 with a study by Katzman in the Archives of Neurology, where they did an autopsy study on a group of nuns who donated their brains, who had a clinical workup, and we knew whether they had a diagnosis of dementia or not prior to death. There were 137 participants in this study, 79% of whom were diagnosed clinically with dementia, and 55% had Alzheimer's disease pathology. There's two really interesting findings in the study. One was that of those who were diagnosed with dementia, 11% had no observed pathology, we have much more detailed techniques now, so we may be able to find pathology now if we re-examined these brains, but at that time they couldn't. And then the other more interesting finding was that there were 9 cognitively normal participants that had a lot of Alzheimer's pathology who, if you'd just been shown their brains, you would have thought they have Alzheimer's disease. And we conduct neuroimaging studies. So, for example, our Path Through Life project in Canberra, we do see people with a lot of brain pathology, a lot of shrinkage, and they're cognitively normal. And that's what's led to this whole concept of brain reserve and cognitive reserve, because we know that there's something else other than the basic biology that's going on that's explaining why some people are not developing clinically significant cognitive impairment. So there's some biological differences that were found in these brains. They had more neurons, but as you can imagine, this has been a source of much research and continued research over the last 20 years. Just to put this, explain it in a different ways of thinking about it. If you thought of participants or people having either a high reserve or a low reserve in later life, there's going to be a point at which, so with our cognition declining longitudinally, we hit a threshold at which we become impaired, and it's only clinically significant when the cognitive impairment impacts your capacity to conduct your instrumental activities of daily living, or just managing your finances, etc. So there's a threshold. So if you have this cognitive reserve, you've got longer before the decline hits this threshold. What we tend to find is people with high reserve actually have a steeper decline. Once they start to decline, it's more rapid. But that's a sort of underlying concept which we use to draw together a lot of the ideas and to make sense of the findings that we have in this field. So that was just the background. I'm now going to talk about some of the enablers. As I said, I usually talk about the cardiometabolic ones. We're going to look at some of the social ones that we also do look at in research, and they're many and varied. So first of all, looking at socioeconomic status, it really goes back to birth. We do find that in systematic reviews that a number of SES indicators are mostly related to well, the most common one is maternal education, impact cognitive function in children and in cognitive development. And this has been found in many studies, and there's a lot of research on deprivation and school performance. Then if we go to our adult literature, we've looked at brains in middle-aged Australians in our Path Through Life cohort. So just to show you the bit of the brain that we were interested in here is the hippocampus and the amygdala, which is shown lighted up on those brain scans, and that's because they're the parts where we tend to see an accumulation of Alzheimer's pathology, and if shrinkage in those brain subregions is usually predictive of incident MCI, so it's a good indicator. If we see something correlates with shrinkage in that part of the brain, we see it as a risk factor for cognitive decline and dementia when we end up getting a clinical diagnosis. So we're very interested in this. In one paper we looked at financial hardship in our midlife cohort, and we did find an association between financial hardship and the volume of those regions. I'll just make that out too. So building on this, we've got work by Kim, who's here today, who's looked at current financial hardship in the full sample. So the neuroimaging is a sub-study in our epidemiological cohort, and there were 431 middle-aged adults in that cohort. And Kim has looked at this issue in the entire Path Through Life project, which in the 3 cohorts, and looked at within-person change in current financial hardship and cognitive function. So looking at how cognitive function changes as your financial hardship changes. And he found in this that there was an association within person, that this varies over time depending on whether or not you're reporting financial hardship at that time. And that was published last year. The particular items that were significant were unable to heat the home, went without basic needs, and an overall hardship severity count. Now, people often think because our sample started off mostly based in Canberra and Queensland, we don't have anyone in our cohort who's experienced this financial hardship, and that's actually not the case. We do have, whilst Canberra is typically a slightly higher SES community, in the sample of about 7,000 participants, we do have a significant number who do report experiencing financial hardship. So there's been other work looking at socioeconomic status and cognitive decline in late life, and this is from the US Health and Retirement Study. So what people have tried to look at in this field is whether you had low SES in early life versus sort of high SES in late life, and whether reversing your socioeconomic status through employment and education opportunities can change your trajectory. And as you would expect, often these studies of SES and health are fairly monotonous. If you have the lowest SES, you tend to have the worst health outcomes, and that also is the case here with cognitive decline. There was some movement here for people whose SES changed over the life course, but the people who moved into high SES didn't end up at the same level as those who maintained the highest level of SES between childhood and adulthood when the other measures were taken. But overall, in this study in the HRS, having a higher socioeconomic status generally predicted slower decline. There's been another study of the English Longitudinal Study that just looked at wealth and risk of dementia. This is looked at 6,346 older adults followed for 6 years. They were assessed on the Libra, which is a Dutch risk assessment tool for Alzheimer's disease. And in this study, the risk of dementia between high and low levels of wealth was partly explained by those modifiable risk factors. But in this study, having the medium or high tertile, there was no difference in risk. It was really the lowest wealth tertile that was associated with a high risk of dementia. And this is in the English Longitudinal Study. So these things are going to differ between countries due to the public health system, which is going to interact with wealth and access to healthcare. And this idea has been taken up more. This is a really interesting paper, and when I read this, I thought there's probably a lot more potential for us to look at this sort of these issues using this methodology. So this paper used the Regional Development Index and looked at that as a way of explaining gender differences in cognitive ageing. And what they found was that in countries with higher Regional Development Index, there's better performance on measures of episodic memory, but their suggestion is that women benefit from economic improvement more than men. And this is seen in this graph because the differences between men and women are actually larger in Northern Europe, and they start to disappear in the countries that have the lower RDI. So I guess it's all suppositional, inferential type of explanations as this type of research, but I think it's without doing international research and using these other global indices together with the individual level cognitive data, we can't start to bring these type of explanations to bear. So it's very interesting. I just wanted to talk about some social enablers now. Again, looking at the US Health and Retirement Study. Often we have a problem in this field of finding actual interventions. So it's very difficult to conduct an intervention on something on cognitive ageing which occurs over decades. We often don't have a big enough time frame to see change. And this is a really interesting study because it's a natural experiment. So the hypothesis in this study was that military service would offset the impacts of low maternal education. And this is really interesting because other people say that military service is associated with trauma and stress, and that's been shown to increase the risk of dementia in US veterans as well. So it's kind of counterintuitive hypothesis, but the idea behind this paper was that people who join the military who come from a parental background with low education have much better access to health and education than people from the same background who did not join the military. And so it's that advantage of that education which was hypothesised to counteracts like a natural experiment of how they could intervene in this social determinant. They had 16% of the sample with maternal low education, 33% medium, 51% high, and they did find that veterans whose mothers had low education did have a reduced risk of dementia compared to people who had low maternal education who were not veterans. So that's, again, not causal data, but also very interesting. There's a lot of talk about lifelong learning and how it's really good for the brain and all this cognitive stimulation, but there's actually very little evidence that lifelong learning, that education in later life actually makes differences. This is probably one of the strongest papers I've seen to show a real impact. So theoretically, yes, it sounds good that we'd have all that extra cognitive stimulation and neurostimulation to do with neuroplasticity, but there's actually very little evidence of benefits of lifelong learning. There's other evidence looking at midlife working hours and late life social engagement. So this is data from Singapore. So again, a very interesting topic because data from the Whitehall study had actually shown that people, civil servants in the UK who work very long hours had poorer cognitive function. But in Singapore, and again this could be a cultural difference, it could be just different measures, we don't know, but in Singapore, midlife adults that worked longer actually had better cognitive function, and that was long-term follow-up of their cognitive function. They were less likely to be diagnosed with MCI, and they also found that adults with high levels of social engagement had lower rates of MCI. So there's been a lot of work showing that socially engaged older adults have reduced risk of dementia that came out of Sweden with Lara Fratiglioni's early work in the Lancet from the Kungshammer project. There hasn't been as much work, in fact, in the systematic reviews, we couldn't find any evidence from midlife adults on the benefits of social engagement for cognitive risk of dementia or cognitive ageing. And one of the problems with that is reverse causality. We don't know if it's just that as people's cognition starts to decline, they withdraw socially, and so that finding we're seeing in the late life literature may be due to reverse causality. So that study is important in showing in slightly younger adults. And there is a growing amount of data now looking at social engagement as protective against dementia. So there was the Swedish data, and now there's work also looking at loneliness and cognitive decline. And so there's enough published now to have systematic reviews on social engagement, loneliness and cognitive decline. We've been involved in a lot of systematic reviews on this topic, and also with WHO guidelines on risk reduction, and there's very little evidence from interventions to show benefits of intervening with loneliness and social isolation. Doesn't mean that there isn't a benefit, but there's just very little evidence. The other issue is with the systematic reviews that every study has used a different measure, so we're really pulling very disparate exposure items. Nevertheless, it does seem to be protective if we take all of that into account. I just put disablers. One of the issues I was meant to be talking about enablers, but a lot of the things I've been talking about have been construed as risk factors. I mean, most of these can be construed either as a risk factor and disabler or an enabler, depending on which way we code our data, of course. And I feel like at the moment with the bushfires upon us, the issue of air pollution has really become much more significant in Australia. Instead of us seeing it as something that happens in other countries, we're really facing issues of air pollution at the moment, and we've been worried about air pollution and dementia now for some time, as the literature has been showing an increased risk of dementia associated with air pollution. But in the dementia literature, often air pollution is linked to roads, and one measure that's often used is proximity to roads. So there has now been this paper, this came out in the Lancet in 2017, that looking at the closer you live to a main road, the higher your risk of dementia. And that was in a very big study from Canada, the whole of Ontario, or particular age ranges in Ontario. But that's also been shown in other studies, and it's been backed up by some biological evidence looking at neuroinflammation in the brains of people who come to autopsy through accidents who've been exposed to high levels of air pollution in Mexico City, and then poorer cognitive performance. So all of the data on air pollution is becoming very consistent that different types of air pollution, whether it's measured through the monitors or through distance to a main road, they're all being linked to cognitive decline and risk of dementia. There's on other environmental factors, I don't have time to go into them all. There's some emerging data on proximity to green space that's coming out as protective. There's some data on pesticides, particularly occupational pesticide exposure, which has been shown to increase risk of dementia. There's very little data on a number of other toxins that are sort of bits and pieces in the literature. One thing that's interesting is there has been studies done on noise, and they don't seem to be noise pollution doesn't seem to be associated with cognition. There's a limited data on urban versus rural settings, with some showing benefits and some showing risks. Another concept that's being investigated is the environmental complexity as being beneficial for cognition, which would explain why living in urban areas is better for cognition. So the idea is that in an urban environment, you have a lot of cognitive complexity, lots of decision making, having to catch public transport, having to navigate much more complex spatial situations. So it's very interesting because on the other hand, you also have more pollution, you have less green space, and so you've got a balance of risk factors, and it's depending on which risk factors being studied, you're getting different response, different outcomes there as to whether, say, living in a polluted, heavy, noisy, but very dynamic and cognitively stimulating environment is better for you than living in a boring rural setting. So that's still out there being investigated. I tried to put all this together. It's actually quite a while ago now. This is in 2012, and 2014. It needs updating, but we tried to pull all of this together because one of the issues about cognitive health is it's just really, really complicated. There's so many factors, and if we wanted to have policy responses, we need to have a big model to fit everything together to work out where to intervene. And this is a really classic example of an interdisciplinary topic. It takes people from all areas of society, both medical, non-medical and policy, because we've got exposures. We've got, with our independent variables, we have some genetic factors which I haven't mentioned. We have all the environmental factors which require policy responses. We've got demographic differences, lifestyle. I think that there's these two disease risk factor areas which are critical to cognitive health, and one is stress, which leads to the mental health conditions, and the other one are the cardiometabolic risk factors, which lead to diabetes and cardiovascular disease. And the cardiometabolic risk factors includes the high BMI and the high glucose that we heard about before. So those things are the sort of central issues when you're looking at brain and cognitive health, and they lead to all the neuropathology, which then leads to cognitive and brain ageing, and that's moderated by your cognitive reserve. So that's the sort of model that we have to improve on and work with to try to pull this together and then develop different responses for intervention depending on which bit of the model we're working at. So just to conclude, the enablers of healthy cognitive ageing draw from economic, social and environmental domains as well as the medical and lifestyle, and they're all interacting. A life course perspective is required, so I seem to have missed out my life course slide, but clearly you can't address this just in ageing. You have to take the whole life course into account. You need a multi-level approach, so a healthy start to life, addressing poverty and disadvantage. Enriched education in childhood is something that we are increasingly feeling strongly about and looking at building the optimal brain health and cognitive development, because we're looking at building brains and cognition in a way that will so that people start off as with the best chance of ageing well cognitively. A clean physical environment, social capital engagement, healthy lifestyle, medical management of chronic disease, all of those factors have to come into play. Thank you. And I just want to acknowledge my team. Thank you.
Thank you very much.
Okay, good afternoon, everybody, and thanks for the opportunity to speak here today at this workshop. I first had the opportunity to meet John at the Global Roadmap to Healthy Longevity. It's a bit of a mouthful, in Washington just in November, and then got the opportunity to come here again today to speak about this. So in that audience, I was asked to talk about economics of healthy longevity, and I think there was only one economist in the room at the time. So some of these terms you'll be more than familiar with. It's a bit of a general discussion into some of the economic aspects, and then maybe some that you're not familiar with as well. So of course, most people here will know opportunity cost is the key to economics of healthy ageing and the economic contribution of older people. I also should note, because some of these slides were made for an American audience, and I switched between the European, Australian spelling and the American spelling interchangeably, so bear with that. That's why it's there. A bit of cutting and pasting going on here as well. So we're interested in economics and the opportunity cost. We cannot leave out the opportunity cost. If we have one option, then we forego something else. There's always a cost involved and trade-offs involved there. So older people are two things. They can be producers of goods. Many people still working after the age of 65 up to 67, and I have a slide, some data on that going in the next few slides as well. Also consumers of goods, we saw this earlier as well, that there's a trade-off now between leisure consumption and hours worked, and if we look at the data now at the moment, it may be that you would think it might be a lean more so towards leisure consumption rather than hours worked. But however, the question emerging there is this a push, maybe due to discrimination? People are not wanted in the workplace, or is it a pull, it's desired consumption, we get to the point of no longer wanting to work, so therefore we make the decision that's our decision to retire before that age. Another important economic aspect is that there's intergenerational wealth and poverty. So going from your parents' wealth, if they're in poverty, if they're in low income, there's a high probability person will be as well, the children will be too, but it also goes in both directions, and particularly in terms of health. And one of my PhD students has just finished a paper, hopefully will get published eventually in an American journal using the HRS data, and she looked at the impact of children's health, so adult children's health, on older adults' health. So it's not just young children, that's the intergenerational effect, but also the adult children, and then because of the caring responsibilities that might come in there, and the informal care arising there as well. So uncertainty of health, prediction of health, future health, and asymmetry of information, maybe the principal aging problem here between doctors and patients, there's an asymmetry of information. So that means that the normal market forces, demand, supply, may not work in the health economics world, so government intervention, public intervention would be necessary there as well. So these points I felt were important to say to a more general audience, interdisciplinary audience, because quite often the asymmetry of information is overlooked, and people rely on demand-supply factors to determine prices and quantity, whereas we know that that's not the case. So these are some of the data I was talking about. So this is just a snapshot of people aged 65 plus in employment. I think that's all employment in various countries around the world. And you'll have figured out by now that I also like Ireland, so I have put that one in there as well. And just a few different countries: Northern Europe, United Kingdom, America, and then New Zealand. So here, if I was this age and I was thinking about where I might get a job, I think I would look at the countries that are more favourable in employing people into older ages. So I think this is quite interesting, and what will be more interesting going forward is after 2020, where may this actually maybe teeter off, or where may it increase, because there's only a certain level of people that can be in employment at that age. Also, the health income gradient is very relevant to this discussion in economics. This is a US map, and life expectancy here. So we saw earlier that life expectancy has been increasing over the years, but in the US, it depends on which state you're in. So here, down in this quadrant here, seems to be lower life expectancy, and this data was between 1990 and 2016. And what's interesting is that if you look at the US as well, that these, you can't really see it here, but the poverty rates are much higher down here. So we have perhaps an interaction between income, poverty, wealth, and also life expectancy. And I think that a lot of what I'm saying here is repetition of what might have been said earlier today. There were the lines where life expectancy was higher for those in the higher income groups. And I chose to represent this, maybe potentially there's similar data for Australia, but I chose it for the US because it was more prevalent in the literature. And before I go on to talk about the next slide and data I have there, and again this has come up earlier, so I was interested to see that as well, that I wanted to look at the old age dependency and show how that is changing and how that might cross over with the young child dependency ratio going into the future. But my question is, we have young age under 15 as the child dependency ratio, and old age as the standard 65 plus. And when I presented this at the Academy workshop in Washington, it was questioned that, well, these age dependency ratios are okay if we're looking at the whole entirety of the world, but actually within countries, and I was glad to see this earlier as well, that this may not be actually appropriate. So I think it's not relevant to today's population in developed countries, in developed countries, but if we look across the whole world, well then it's just a way of comparing across the world in different countries. So we continue to use this for the moment, but I think it's open to debate, and I think we can actually, it's easy to tweak within country analysis. We can do this within countries and see what might be appropriate, maybe 18 to 20 and then 67 to plus, depending on the statutory retirement ages there. So this is what it looks like in here up to 2020. You can see that the child dependency ratio, as per this definition, under 15, as a proportion of the working force age 15 to 64, has been decreasing, but the old age dependency ratio has been increasing. And this is going to change going forward, and this is the Australian data. And so by 2060, or just before, there'll be a crossover here where the old age dependency ratio, as per this definition, will be different, will be higher than the younger age one. So I think that's quite important for it has a lot of implications financially, for the healthcare use, even for informal care, for across the spectrum of people's lives. So given all that data, sort of a snapshot really, there's several other data we could look at. What would be the emerging questions? So in terms of economics, maybe what costs are likely to occur. So if we want to look at the cost, we'll have to start with maybe healthcare resource utilisation. So I do a lot of work on that, looking at the impact of falls, cognitive decline on healthcare use. So that's the starting point. And then we can attach costs to that, predict forward into the future. And that's generally done from the healthcare perspective. If we're looking at the government level, where they make decisions on what interventions to fund or what drugs to fund, they generally just look at the healthcare perspective. But we also should really look at the societal perspective and look at the consumer costs, the out-of-pocket costs for people, the productivity costs, what's the loss to the economy if people are unhealthy. And so to do this, we'd have to follow the care pathway of an individual from when they become unhealthy, when they enter into the healthcare system. So if they start by going to the GP and then they move onwards into hospital, out of hospital into community care and then back into work, that's the whole care pathway really. But to be able to do that, what we need is data that will follow them the whole way through their journey. So using the studies that were mentioned earlier, for example, the Australian Longitudinal Study of Women's Health, or comparison, the HRS, the harmonised studies across the world, that's okay up to a point, but we need to link in the data from other parts as well of the system to be able to ensure that we can follow them all the way through. So linking the healthcare sector data with community care data, social sector, is a bit tricky, and there's not that many databases of that available yet around the world, but that would be the ideal, I think, data available to us. Another emerging question are health shock effects. So if we have an acute onset of a condition, for example, become ill with cancer, or for an older person, if they have a fall, that's an acute shock, or even if they have a recurring chronic condition. The question may be, how do these impact on work decisions? But we have to remember that it's not just about correlations, and there may be reverse causation in the data. So if you're in a job that, say for example, manual labour, that may lead you to fall or lead to a physical problem, or even a mental health problem, or combined both physical and mental health, then there's reverse causation. And when we do the analysis, we have to allow for this in the data as well to get the actual causal effect. So that's a huge, huge contribution from economics and econometrics, where we have metrics based on economic theory from a microeconomic model, microeconomic point of view, and starting with the health production function, and then looking at the impacts of the acute shocks on that. Another interesting question is, I think this was also talked about earlier, is it ageing per se, or is it simply end of life expenditure? So to answer that, because I think that's a really interesting question, or to attempt to answer it, this is not news. This was looked at by Peter Zweifel and authors in 1999, where they had the red herring hypothesis, and they wanted to look at, well, was it the fact that people were getting older, or is it due to end of life? So looking across the whole spectrum of the age distribution, they figure that the real expenditure comes in the last quarter of life. So I know it was mentioned earlier that it's 18 months, so in fact that kind of rings through there as well, that it's the end of life expenditure in the last year, last quarter, last half year of life. So this often, I bring this lecture to the health economics class, and it often confuses the students at, what do you mean it's not aging per se? Everybody's getting older. So what it is that it's end of life. It doesn't matter if you're 35, 45, 65, 75, 85. So it's end of life, but the fact is that with the demographics on an aggregate level, on a macro level, the population's getting bigger, so therefore the whole expenditure is going to increase regardless. And then this sort of analogy was updated in 2018 by Howden and Rice in the Health Economics Journal. And again, they showed that it's time to death in quarters, so it's more expensive. It's just a reverse of the chart here. More expensive in the last quarter of life. So how can we use economics, the data, the metrics, to answer some of those questions that I've touched on? I know there's several others, but these are the ones that I would be mainly interested in. Using the cohort studies, the longitudinal data, the administrative data, and linking those together, that's fantastic to look across the spectrum. So that means that government departments can't work in isolation, they have to work together to link the data. And I think here in Australia that's pretty good. Some countries it's a lot trickier and a lot harder to actually link up the data there as well. So these studies, the harmonised studies across the world of the ageing, so populations age 50 plus, these are fantastic studies. There's the Chinese, the US, the European one, there's the Irish one, English one, a few others as well. And what's missing to me is an Australian one. And this often causes issues when we want to look at these questions in the Australian context. Students are PhD students dying to do this and use Australian data. There is the women's study, but if they want to look at men and women, there's the New South Wales studies, but there's a limit in trying to harmonise that then to try and look across countries. So quite often we use the Health Retirement Survey to answer some of the more tricky questions. Sometimes the English one, but they didn't actually link in the healthcare use data effectively. So the HRS is probably, or the share up to a point, up to wave 4, is probably one of the best at the moment. And of course, I shouldn't say one of the best, I think probably Tilda is really well out there as well, and including all the questions. So we can use all of that data to focus on healthcare use, which is a favourite topic of mine. Workforce planning, some people are interested in determining what kind of a workforce is needed in the future. And we shouldn't leave out, and this has already been alluded to in the first talk today, the health needs of people have to. So the workforce planning has to be based on the health needs of people as opposed to just the numbers, but actually what health needs are there, and then we work forward on what sort of carers, what healthcare resources are needed into the future. And we should look also in terms of predicting healthy longevity as opposed to, at the moment, the standard age 65 plus. So there's been so many examples here today that have been really all interesting and great, using these data already, but here are two more. One of my own on looking at the impact of cognitive and sensory impairment on healthcare use. So this was part of EU Horizon 2020 project called SenseCog. Some of you might have heard about it. And so that was looking at the interaction between sensory impairment and cognitive impairment, and then the impact on healthcare use. So we did some econometric modelling on that get out the effects as best causal as we could. And then I like this paper here, the impact of falls, because I'm very interested in the impact of falls as well. And in using the HRS data, this was published in Journal of Economics of Ageing, and he tried to extract the causal impact of falls on health outcomes, which you'll see in the next slides. I'll show some of the results. We put them onto graphs for ease of exposition. Are quite tricky to interpret, and so I think that's important to say as well, is that by reading the papers and getting at the effects that some people get, it's important to really look into them, because particularly in this one, what you see here is that it's the marginal effects, so it's the effect of the number of falls on the probability of good health. So it shows reduced good health, which is good. I mean, which is probably what happens. It means it's in the right direction. ADLs, depression is increased, psychological problems. So they, to me, all make sense. However, this author had said that this was a causal effect using an instrumental variables approach. However, I think we need to read into it more carefully about effect on cancer. I'm not so sure. Heart disease. People who are more broadly interested in the medical field will know more about this, if this is correct or not. I would say more so that these are just associations rather than causal effects. And then another variable he looked at was more than one fall. So having one fall probably leads to another fall for older people. So it's good to look at more than one fall. So again, that has the same sort of impact. Hugely has an impact on ADLs and depression there as well. For the cognitive, this cognitive impairment and the interaction with sensory impairment, this here shows the doctor visits, so that's generally GP visits, maybe some other specialist visits as well. And here you can see cognitive impairment only hasn't any effect really. Not a lot of these are significant anyway, so that's another story. The sensory impairment leads to more visits, and then the two together even more. So I think that's an important finding there for both doctor visits and GP visits. So some points I'd like to make on, how can we leverage the change in populations and be successful. So rather than just taking the medical approach, so it's the more interdisciplinary approach, rights-based approach, social model might be needed to look at the individual heterogeneity. We need to have better understandings of language across countries and around the language of work. So rather than talk about retirement, can we just talk about work? Older people, older citizens, senior citizens not aged. Every time I go past this age sign here, I don't like it. It would be better if we could be called older people or senior citizens or something. But that's just different languages across countries there. And we also have to remember that everything has an opportunity cost and trade-off. So we'd like to think that we can have independent living that's cost-effective with good quality of life in the future. So to quote, so before I met John Baird today, I'd actually quoted him back in the workshop in Washington. This is an article I had read, editorial in Economics of Ageing, Journal of Economics of Ageing, where this struck me. So in general, does the economics research conducted on ageing match the needs of policymakers and other stakeholders? Simply no. So that was music to my ears for somebody who's interested in economics of ageing research and also an opportunity and shows us that there's a lot more to be done as well. To that end, I think research partnerships are important. We can't have academia working on its own. It's got to be in conjunction with policymakers and stakeholders, consumers themselves as well. So that concludes. I was under a bit of time pressure there at the end. And thank you for the opportunity here and also to acknowledge some help I got with the grants from students there. Thank you.